Good evening, everyone, and welcome to this webinar, which is about cryopreservation, which means freezing and long-term storage. And we're going to talk a little bit about freezing eggs, sperm, and embryos, which is something that we do very regularly every single day at a fertility clinic. So I'm Dr. Sarah Wakeman. I'm the Medical Director of Fertility Associates Christchurch. So the things that we're going to cover in this talk are what do we mean by cryopreservation, who is it for, how is it done, and then time to answer questions at the end. So please feel free to send questions in. And I've got Kelly from marketing in the background who will just sort them through. She'll make sure that your names and things definitely aren't in there and sort them through so that we don't get repeat questions as well, and that hopefully we can answer them all at the end. So what is cryopreservation? So in simple terms, a good way to describe it is freezing for the future. So we can freeze eggs, sperm, and embryos, which are fertilized eggs, and they're frozen, and it's almost like they're suspended in time. And the idea is to allow the chance of pregnancy in the future at a later date. We can also these days, or have been for quite some time, being able to freeze ovarian tissue. So that means actual pieces of somebody's ovary. And also, as part of a study, much more recently, we can freeze some testicular tissue, but that's only from boys before puberty, before they would be making any sperm, and that's still experimental. I'll talk a little bit about that, or very briefly about that at the end. So who is cryopreservation for? I mean, it's for many people, really. So some of the main groups, people facing an immediate threat to their fertility. So somebody who's faced with cancer treatment and going to require chemotherapy, radiotherapy, surgery to remove their ovaries or their, if it's a male, their testes. In some cases, other medical or surgical treatment. Vasectomy is a threat to your fertility. And people may want to consider freezing sperm if they have a vasectomy, in case they change their mind in the future. Transgender people, and I'll talk a little bit more about that. It's for people who are wanting to protect their future fertility, and in particular, we see women wanting to freeze eggs because they're perhaps getting older and haven't met the right person yet. And it's very much for anyone. Cryopreservation is for anyone doing IVF for fertility treatment, because freezing extra embryos, fertilized eggs, is a really important part of IVF, and it's where a large proportion of our babies from IVF treatment now come from embryos that have been frozen. So it's a really, really important part of running a good IVF program. So I'm just going to talk a little bit more about each of those areas. So people facing cancer or other medical or surgical treatment that's a direct threat to their fertility, people who are going to have their ovaries or testes removed, often that would be for a cancer or suspicion of a cancer. People who are going to have chemotherapy, because the chemotherapy drugs, they target rapidly dividing cancer cells, but they also damage the immature eggs in the ovaries and the cells that produce sperm in the testes. And so people can come out of that with no eggs or no cells that produce sperm left at the worst, or a reduced number. So, like I said, they can be left with a smaller number of those cells, and therefore perhaps run into problems in the future, or perhaps if it's really severe, they may be left with none at all and have a problem right then and there going forward. Radiotherapy, the way radiotherapy works, it's about what area of the body is in the target area. So if the ovaries or the testes are in the target area, then they will sustain damage. With radiotherapy, often you might be targeting one particular thing. You might be targeting some bone in the pelvis, but if the radiation field then includes an ovary or testicle, then a byproduct of that could be problems with fertility later. So transgender people, that's, they're an important group of people that we see. If they have medical treatment to help them transition, then that would almost always involve hormones, and those hormones can affect how their ovaries or testes work. And some of them may go as far, the usual thing is to start hormone treatment. And then after a period of time, if people are sure that that's what they want to do, they may then go on to have their ovaries or testes removed as part of transitioning. So a little bit more about all of that, what's called the gender affirming hormone therapy, so the treatment to assist them with becoming the gender that they want to be. For people who start or assigned female at birth, so the transgender male, they need to take testosterone to get those masculine effects, so deeper voice, more body hair, increased muscle mass. The what happens to their female reproductive organs. The uterus tends to atrophy and get smaller, but that's temporary. And the ovaries are suppressed. It usually prevents ovulation occurring and will prevent periods, which they may well be quite pleased with. But the really important message about this is that it's actually reversible and quite quickly reversible if the testosterone is stopped. So that means that these transgender men can actually stop the testosterone and go on and do an IVF cycle to collect eggs at any point in the future, or at any point until the normal age that you would be able to do that. They may go on to have their ovaries and uterus removed, and if they're going to have their ovaries removed, well then that's different, because there wouldn't be any ovaries there to produce eggs in the future. For people born assigned male at birth who are transitioning to become female, so transgender women, they take estrogen to have the more feminine or female effects. As a result of that, their testicles will atrophy and become smaller. Sperm production will stop. So for a start, they may well go through a period of time where there's lower sperm counts and less sperm production, what we call hypospermatogenesis. But then they'll almost always become azoospermic, which means no sperm production. This might be or could be reversible, but if the estrogen is stopped, but it can take a really long time once something like that's happened to stop sperm production. It can take a really long time, and it may not be reversible. So this group of people in particular, we'd rather give them, it makes more sense for them to have the opportunity to bank sperm and freeze sperm before they transition, rather than 10 or 20 years later. And because they may have to stop estrogen for a long time in the future if they wanted to be able to produce sperm, they can have a lot of side effects from that and find that quite difficult. Whereas for the transgender men who are taking testosterone, the latest evidence is that they may not need to really stop it for any period of time, and that we can stimulate their ovaries to collect eggs. So and going through an IVF cycle is a lot more involved. So we would normally leave that until they actually really want the eggs in the future, rather than doing it before they transition. And the transgender woman may go on to actually have their testes removed as well. So options for transgender people before puberty. So if they're transitioning before puberty, the options are a lot more limited and this is actually options for everyone for fertility preservation. So before puberty, options are limited. For boys, as I said, we are now freezing prepubertal testicular tissue, so for boys who haven't gone through puberty yet, as part of a study run out of Starship Hospital. So people would have to be enrolled in the study and meet the various criteria in terms of what cancer they had. It would normally be a boy with cancer, what the treatment was going to be, what the risk was. The problem with this is we can do it in the same way that we freeze ovarian tissue, but what hasn't happened yet is that there isn't yet the proof that this can be transplanted back into an adult male in the future and actually produce sperm, whereas that's well established for freezing ovarian tissue for females. So it's been proven in some type of monkey, and the hope is that it will be possible in humans, but it hasn't happened yet. So at the moment, it would very much be classed as experimental. After puberty, things are a little bit easier. So for someone who's born male to freeze sperm, most of the time they'd be able to produce a sample via masturbation and ejaculation. Occasionally they might need assistance with that, with electroejaculation. and very occasionally we might, we might need to do a little surgical procedure and collect sperm from the testes as well. For anybody with cancer, it's important that that's done before the chemotherapy starts. And for transgender patients, we'd want to stop any estrogen treatment for a good 3 months, and we'd want, and have to check that there's actually sperm present. But ideally, they bank before they start the treatment. If somebody isn't able to produce a sample in the normal way, the most common thing, that we would then aim to collect a sample surgically, and that's usually a small procedure that we can do at the clinic under local anaesthetic to collect some sperm from the testicles. So for women or transgender males, before puberty, we have got the option of freezing ovarian tissue, because for women, the ovarian tissue contains all the little immature eggs already. It was considered experimental for a while, but there's now been quite a large number of babies born worldwide, but the only use of that tissue is to transplant it back into that person in the future. So it's most commonly used in a cancer situation, and then when the woman's older and has recovered from cancer, if the remains of her ovaries no longer work, she could have the tissue transplanted back. After puberty, we can freeze actual eggs. And as I'll show you, that involves going through an IVF cycle. So for cancer patients, we want to do that before chemotherapy starts. For transgender patients, we'd want them to usually stop testosterone, and we've got increasing evidence now that they probably don't need to stop it for very long at all. So that's makes things a lot easier for them. And the other option that females have got is that they could fertilise the eggs and freeze embryos, particularly if they've got a male partner who can provide sperm. But we're always very clear with them at that point, particularly if it's a young woman with a cancer, that if they choose to do that, the embryos belong equally to them and the male partner. They don't have any additional right over them just because they had cancer or just because they were the one that went through the IVF cycle. So, that's an important consideration for people. So age, a number of people may choose to freeze material because of increasing age. So, why is this such a problem? So for females, as many of you may know, we're born with all the eggs we will ever have. That number is just decreasing in the background all the time, even when we're a child, even when we're pregnant, even when we're taking the oral contraceptive pill and not releasing eggs, we are still losing immature eggs in the background all the time. And everyone will eventually run out of eggs at some point. And, that's the time that they run out of eggs is basically the time of the menopause when they have their last period. So the way we can get some kind of measure of how many eggs women have or females have in their ovaries is with AMH, anti-Müllerian hormone. So that's a hormone produced by some of the little immature eggs at a certain stage of development, and most of the time it gives us a pretty good idea about the number of eggs remaining, although there are some situations where it's not quite as accurate. So this graph shows the solid black line is the 50th centile, so that means half the women at any age have a level, around and above that line, half around and below. So it's really the woman with the lowest levels of AMH that we tend to have the more difficult conversations with, because it means they've got less eggs remaining for age. Maybe they've got less time in which to become pregnant. They may go through the menopause earlier. And also treatment can be more difficult, if they're trying to do IVF to collect eggs to freeze them. The lower the AMH is, the less eggs we get from one IVF cycle as well. So that certainly makes it more challenging. So quality is related to age, so the older the eggs are, because they've been there since birth, the lower the quality and the lower the chance of pregnancy. AMH is about number, and the two things tend to go hand in hand. As people get older, we expect them to have less eggs and lower quality eggs. So, the other important thing is, that age and quality of the eggs means that the chance of getting pregnant with those eggs is lower. So you can see that somebody who's perhaps 29 years old has maybe a 23% chance of getting pregnant naturally in one cycle. So that's if they're in a heterosexual relationship and able to try for pregnancy. But that goes down as the woman gets older and her eggs get older. At 35, it's maybe a 16% chance per cycle, and at 40, down to a 5 or 6% chance per cycle. And by the time you get to 44 or 45, you're getting to extremely low chances. So, people may want to try and freeze some of these younger eggs to give a better chance of pregnancy if they're not in a position to become pregnant at that point. And this is just another way of looking at it. So the purple line is the chance of pregnancy per cycle compared to age, and you can see that it drops quite steeply, really from the mid-30s on. And the dotted red line is the chance of miscarriage per pregnancy at a certain age, the percentage chance of miscarriage, and you can see that that goes up, in the same way that the chance of pregnancy goes down. So because the eggs are older, they're more likely to have the wrong number of chromosomes and you're more likely to have a miscarriage. So it's a bit like a double whammy. So what about male age? There's always a lot of focus on female age, and a number of people are aware that, women being older definitely has issues for fertility. But, males don't completely escape this. It's not quite as severe for men, but, men getting older does reduce the quality of sperm. So unlike women, men actually do keep making new sperm. So they have the cells that make sperm in their testes, and they can keep making new sperm. And so everyone will be aware of the occasional much older man in their 70s or even 80s that's managed to father a child. But despite that, the sperm isn't as good as men get older. So the sperm numbers and quality do decline with age. Older men, an increasing percentage of men by the time you get into 60s, 70s, 80s will have sexual dysfunction, which can obviously make trying for pregnancy a lot harder. There's also definitely a higher rate of miscarriage for women when the male partner's aged over 40. I mean, often the woman's older at that point as well, but even if the man has a much younger female partner, there's an increased risk of miscarriage. And there's definitely a higher rate of abnormalities in the children born to older fathers, things like schizophrenia and autism. There's a lot of much rarer conditions which have an increased rate as well, but they're rare in the first place. So even when they're doubled or tripled, they're still they're still rare or very infrequent. But schizophrenia and autism are two conditions that aren't that uncommon. So it's something that we tend to talk to people about. And the studies that show that tend to classify men as older if they're over 45 or particularly over 50. But that's been shown in a number of populations around the world. So, age does matter for men as well, although not quite as dramatically as it does for women. So how do we collect eggs for women? Because, for most of the time for a man, collecting sperm is fairly straightforward, but it's harder to get the eggs. They're in the ovaries and not so easy to get to. So what we need to do is one or more IVF cycles, and in simple terms that means about 2 weeks of injections to stimulate the ovaries. So instead of just getting one follicle or egg to grow up to a larger size and ready to release, hopefully we have 6, 8, 10, 12, a larger number. The number that we have will depend on the number of eggs in the ovaries in the first place. So someone who's got a high AMH level and signs of lots of eggs in the ovaries is much more likely to get a higher number of eggs from an IVF cycle, and someone who's got a low AMH indicating not many eggs remaining in the ovaries is much more likely to get a much lower number, which is why for some people they may need to do multiple cycles. So it's usually the 2 weeks of injections, a couple of scans along the way to check what's happening, the egg collection procedure, and then the eggs are frozen within about 2 hours of egg collection. So the injections people often worry about, but really they're just in pens as if you became a diabetic. They're fairly easy to use. They're little fine needles, and the injection just goes under the what we call subcutaneous, which means just under the surface of the skin, and people are taught to do that at home themselves. On the right, you can see a picture of an ultrasound scan. This is an ovary with quite a large number of follicles that are clearly getting bigger. So on a scan, on a cycle, these would be counted. The largest ones would be measured in terms of diameter, and as soon as we've got 2 or 3 that are about 18 millimeters or more, we'd be planning the egg collection procedure. And this is how we do the egg collection. So, this is a diagram showing it's vaginal ultrasound, it's local anaesthetic injected into the vaginal wall and a needle through into the ovary to drain the fluid from each of these follicles, and inside each one, hopefully there's an egg. So hopefully we get around 80% of the eggs. We won't always get every single one, they're microscopic. The woman, this is just a procedure that takes 10 minutes. It's just done in all of our clinics. The woman has a little IV line in their hand to have some sedation, and most people cope extremely well with that. And this is what an egg looks like under the microscope. So this is a beautiful mature egg. An egg's about 1/10 of a millimetre, so it's the largest cell in the body. And, this is what our scientists, our embryologists, will be looking down the microscope as we pass the fluid that we've collected through to them, and they will be looking for, for these eggs, and they'll be giving us a tally, and at the end of the egg collection procedure, we'll know how many were collected, and within a couple of hours, they will be frozen. So, one of the things we really talk about or try to emphasize with people when they're looking at freezing eggs is what is the chance of pregnancy if they've got a certain number of eggs frozen. So on this graph, you can see on the bottom the number of eggs frozen from none up to 21. And these lines are for different ages. So somebody who's younger, 30 to 34 years, no matter how many eggs they've got frozen, they're going to have a better chance of pregnancy than someone who's 38 to 40 or 41 or 42. So, if you're 41 or 42, even if you get 20 eggs collected, we're still talking only around a 40% chance of pregnancy because the eggs are older and just going to individually have a much lower chance. So this is really, information that we talk to people about before egg freezing, in particular once we know their AMH, so we can be a bit more realistic about how many cycles they might need to do. And then it's what we talk about after every IVF cycle as well, so that they're, if they did get a lower number of eggs collected, they know what the chance of pregnancy is and can use that to help decide whether they do more cycles or not. So, that's really important. It's all very well thinking you've got a certain number of eggs frozen, but really you need to know what the chance of pregnancy is if you came to use those. So, collecting sperm, usually via masturbation, sometimes electroejaculation, sometimes someone who's had a spinal injury, that might be used. And for a small number, a little surgical procedure to take a little biopsy sample from the testicle and hopefully find sperm in that could be frozen. And on the right there, you've just got a picture of what some sperm look like down a microscope. So most sperm, you'll see a head and a mid-piece and a tail. There's always some, like that one, that's a little short stumpy one. There's always some sperm that don't look normal. That's sort of completely normal finding in men. All the sperm don't look normal. Sperm work in large numbers, whereas eggs, we have much smaller numbers of those. So what about embryos? Embryos are really important at a fertility clinic for IVF treatment. Freezing embryos is really important. So embryos are fertilized eggs. So that's when we put the egg and sperm together, they react, and the next day we have a fertilized egg or an embryo. So we need to obviously put the woman through an IVF cycle to collect the eggs. We put the sperm and eggs together in the laboratory. And then the next morning, we know how many have fertilised, and around 70% is normal, so the people doing treatment will be informed about that. And then we wait and see over the next 5 to 7 days how those embryos keep on growing and dividing. And it would be fantastic if they all kept on growing and became a blastocyst embryo, which is an embryo which is a ball of 60 to 100 cells 5 or 6 days later, but in reality, it's often only a quarter to a half that keep on growing. So, we will always update people at that point and tell them how many have been frozen. So we can freeze embryos after 5 days, 6 days, and very few. There's the odd one that just takes longer and gets frozen on day 7, but not many. So the aim would be to have some extra frozen embryos really for everybody's IVF cycle. It doesn't always work out that way, but the advantages are that if there are extra embryos frozen, then those are extra chances of pregnancy. So from one egg collection procedure, you might get multiple tries at pregnancy when an embryo is placed into the uterus. And we'll have a good number of people who have a second or sometimes even a third or occasionally a fourth baby from one original IVF cycle and egg collection because they've been able to come back and use their frozen embryos in the future. So this is just a picture of embryo development. So top left, this is a fertilized egg, and you can see those two circles there are the pronuclei. So that's what the embryologists are looking for to show that the egg has fertilized. This is, later that day or the next day, an embryo with 2 cells. By 2 days later, we should have an embryo with 4 cells. By 3 days after egg collection, 6 to 8 cells. I mean, this is a 2-dimensional image and the embryo is 3-dimensional. Day 4 is not a good day to look because the embryo is going through a lot of change, and it's what we call a morula, and the cells all sort of coalesce and it's hard to say anything. But what we hope is that by day 5 or day 6, we've got at least one that looks like this, which is a blastocyst. So there's around 60 to 100 cells in this. There's a little ball of cells here called the inner cell mass, and if this turns into a pregnancy, this bit will be the fetus. The outer part will be the membranes and the placenta. So that's what a blastocyst is, and that's the stage at which we freeze embryos. So with IVF and freezing embryos, one of the things, important things is the chance of pregnancy. So this is the chance of having a live birth for one IVF cycle for women at different ages. So you can see that when a woman is younger, they've got a close to a 50% chance of having a baby from one IVF cycle. As they get older, it drops. So we can do IVF, but at the end of the day, we can't. We can't get past the eggs being older, and the chance of pregnancy is still very much influenced by the age of the eggs, which is why some people may want to freeze more eggs or embryos when they're younger. So we do have several packages available where people can choose to bank a number of embryos for the future and perhaps also test them to check that they have the right chromosome number. So some people will come in and have a conversation around wanting to have 2 or 3 children and trying to make sure that they achieve that by perhaps doing IVF and banking embryos. So briefly, just talking about ovarian tissue and testicular tissue. So ovarian tissue means actually freezing part or all of an ovary, and that would normally be done for girls with cancer before puberty, where it's too early to put them through an IVF cycle. Occasionally it might be done for a female who's already gone through puberty if they've got some kind of cancer and need to start treatment immediately and don't have 2 or 3 weeks to go through an IVF cycle. So you've got to actually do a surgical operation, a laparoscopy, keyhole surgery, to get in there into the abdomen and pelvis to get to the ovary. So, that means an operating theatre and a general anaesthetic. Part or all of an ovary will be taken. It will be brought back to the fertility clinic. It will be carefully prepared, sliced into very fine slices and frozen. And then the only way that can be used in the future is to transplant it back into that woman that it came from. So that's another operation. And it can be transplanted back into different places. Often it's transplanted back into what remains of the ovaries because some of these women will freeze tissue and never need it in the future, but if they're menopausal, if their ovaries aren't working, then putting some of the frozen ovary back could allow them to become pregnant or allow eggs to be collected from that tissue. So it's quite a big thing to go through, and it's not always going to be successful, but some people have no choice, but that is the only choice they've got. As I said, testicular tissue, it's experimental. It would only be from boys before puberty normally facing cancer treatment. And at this stage, it hasn't yet been proven that you're going to be able to transplant it back and get it to work in the future. The hope is that that will be the case. Like I said, it has been done in a monkey. So the hope is that that should be possible in humans, but it hasn't actually yet happened. But in a number of, there's been a number of countries where they have been freezing tissue like that for a few years. So I'm sure with time, we will find that out. So how are these things stored? You know, people quite often interested to know where is their material stored. So it's stored just like in this picture, in tanks in liquid nitrogen. They're squat and short. We certainly had no problems in the Christchurch earthquakes with any of these storage tanks. The material, sperm, eggs, embryos, or tissue, it's frozen in liquid nitrogen at about minus 196, so essentially minus 200 degrees. What's really important is that it doesn't seem to deteriorate at all with time. You know, we've all used sperm, eggs, and embryos that have been frozen for a long time, and there's no evidence at all that the chance of pregnancy is less. The chance of pregnancy is, you know, is related to what the chance was at the time, you know, that it was frozen, but there's no reduction in chance just because it's been frozen for 10 years compared to 2 years. Legally in New Zealand, what's really important and what we very much emphasise in all the consent forms and to people is that you can store any of these things for 10 years. After that, you have to formally extend the storage period and be granted an extension. Otherwise, the law is black and white, and the fertility clinic has no option but to dispose of those eggs, sperm, or embryos. That we can't. We're breaking the law if we then keep them frozen. So that's really important. We're pushing for some changes to that law because it's definitely not perfect. But you know, at the moment, that's how the law stands, and particularly people who've frozen. Because they're transgender, because they've got a cancer, something like that, where the intention is probably very much long-term storage. It's really important that they're aware of that and that they have the opportunity to extend the storage. So, you know, we make sure that we keep in contact with them. We make sure they know to change their details with us. We make sure that we have a couple of extra contacts on their consent forms so that if we can't find them in 10 years, we might be able to get hold of a family member or friend and get a message to them. You know, we try quite hard with those people to make sure that their material is there for them when they want it. So this is just a bit more detail about the storage tanks for anyone that's interested. So, you know, they're literally big tanks. They're filled with liquid nitrogen. You know, they have to be topped up regularly. The liquid nitrogen levels have to be monitored. They're all on alarm systems these days. And inside the tanks, you have a whole lot of these canister things. And inside the canisters, there's then outer straws and then very fine inner straws with the material frozen. And everything's very carefully you know, very carefully labelled as well. But you know, any one tank will hold a lot of different samples. So that is the end of my talk.